everyone. Can you all hear me? I hope so. All right. Good evening, and welcome to another webinar. And thanks for joining. Obviously, if you're in Nigeria, in the UK, it's evening, and at the moment, if you're in North America, it's the afternoon. So thanks everyone for joining. Can you hear me? Some mercy, thumbs up. Perfect. Thank you so much. So today we're going to talk about something that is really interesting, but I just wanted to start out with a few facts, which are always really good to start out with so that we have a perspective of why we're doing what we're doing. The WHO, everyone knows, talks about the fact that we have 1 in 8 people that actually are suffering from obesity. And this is over 1 billion people, including 880 million adults and 159 million children who are living within the obesity margin. And we all know that global obesity is a global pandemic, which fuels things like diabetes, heart disease, and infertility. Now, I can remember waking up and saying, oh my God, this is like a major problem that we're all facing. But imagine if you woke up one day and then all of a sudden, Oprah steps out looking really slim. And then suddenly Hollywood is actually buzzing, right? Elon Musk credits it to Wegovy. Kim Kardashian talks about the fact that she actually has dropped pounds by taking these injections. And everyone is just looking lean and you're wondering, what am I still doing? So it's actually no surprise that GLP-1 medications, which includes Wegovy, Mounjaro, and Ozempic, and some of the other medications actually dominating this conversation. So I think what's really important is that we all know about weight loss. We know about the fact that it shapes your metabolic health and actually offers not just fat reduction, but also does a whole full body reset for you. That's what has been credited to GLP-1 receptor agonist, right? So today we're going to do something that is a bit different, which is we know there's a weight loss hype about all these medications, but I also want to explore what else can actually happen. When we talk about the fact that there's a full body reset, what really happens to our fertility, what really happens to our reproductive health. Are we missing something? Is there like a link that is missing? Is there some science that actually supports this? And I think there's no other person to join us with this conversation apart from someone that is a leading expert and a world-renowned bariatric and gastrointestinal surgeon who is actually recognized as a leading authority in metabolism and weight regulation and obesity treatment. He's actually been classed as a health public figure and actually takes a big chunk of actually making decisions about what has to happen with healthcare, especially when there is something goes wrong. The nice thing about Dr. Andrew Jenkinson is that he's not only in the forefront of GLP-1 treatment like Mounjaro, Ozempic, and Wegovy, but he actually bases his treatment on evidence-based medicine and is actually patient-centered in his approach. He's also a bestseller, both at Sunday Times and Amazon bestseller for 2 books. One is called Why We Eat Too Much, which actually guides you with why you're eating too much, and obviously being one of the statistics for this 1 billion people living in the world. And also his latest book on how to eat and still lose weight, which has actually really shaped the conversation about appetite, metabolism, and obesity. He's also contributed more than 100 scientific publications when it comes to research with metabolic health and obesity. And everyone actually takes out time to come and visit Dr. Jenkinson. Thank you so much, Dr. Jenkinson, for joining us after a busy day at work. And I know you're still at work, so I'm really grateful you're here today. Thanks, Andrew. Thank you so much.
The pleasure. Always a pleasure, Dr. Chi. Thank you.
Thank you so much. So I think I'm going to just do a few house rules, right? Everybody that's joined, as you all know, you're muted, but there's a chat box. So I'm happy for you to send your questions as we continue the conversation to the chat box. There are 2 people that can collect your questions. You can send this directly to me, or you can send it to Martina Faimali. She's also a surgeon, and she will just populate the questions. We're going to start out with some of the common questions, and then you're allowed to have a conversation. So this is your opportunity to actually speak to Dr. Jenkinson one-to-one and get him to address some of the things that people are worried about, like, are we taking too many of these medications? Are we like, is it going to affect us? Is it really working or not working? And that's what we hope that we can address today. So please just send in your questions and we will try to get to them as we go along. The other thing I was going to say is that Dr. Jenkins is actually at work, so people might come in to interrupt him in between, but we're going to try as much as possible to keep that conversation going without actually too much disruption. So thanks everyone who has joined. I just believe that information is so key for everything that we have to do with healthcare. So thank you so much, Dr. Jenkinson, once more. Thanks for joining us.
Thank you.
I know I've talked a lot about what you do, but I think people always want to hear from the horse's mouth, right? So I was going to let you just speak a bit about what you do, especially when it comes to medications and your work with bariatrics, and then we're going to start the conversation.
So thanks again, Dr. Chi. So I'm a bariatric surgeon at University College London Hospital, which is probably the flagship UK NHS hospital. I do a bit of private work at Cleveland Clinic London. And I've been in this field of weight regulation for about 20 years. And I sort of noticed that doctors aren't really trained very well in weight regulation. When I, was, started to to speak to patients and things. And so that's why I was intrigued by, how human weight is set. Why do patients say to me, I can lose weight on a diet, I can lose weight by going to the gym, but it always goes back on. It always seems to go to a particular set point, an individual's sort of set point, which can be at an unhealthily high level. So we call that the weight set point. And that really explains, this theory of someone's weight being so deranged that it just always wants to go back to a high level, despite me trying to pull away from it with dieting. This is the weight set point theory, which fits in with everything that people say about weight loss. And I was intrigued by, this whole area. So I wrote a book. Actually, I first started doing some lectures for GPs, and GPs said, look, you need to write a book on this. This is really interesting stuff. So I wrote my first book in 2020. It was published by Penguin. It was called Why We Eat, and then in brackets, Too Much. And that really laid out, this thesis or this idea of how human weight is regulated. And it became a Sunday Times and Amazon bestseller. Had many different sort of public podcasts and speaking platforms to get these ideas across, and it's a really misunderstood condition, obesity. So in a nutshell, we have, as humans, a really, really effective, usually, weight regulating system. Just like our heart is regulated, our kidneys are regulated, our liver's regulated, so our weight is regulated, because it's all about energy storage. And we have a hormone called leptin, which comes from our fat cells, and the fatter we get, the higher the leptin level. And that should then be read by this part of the brain called the hypothalamus, which should then automatically shut down appetite, increase metabolism, and bring the weight back to a normal level. But it goes wrong. Leptin goes wrong and can't be read in the presence of, I'm getting a bit complex already, in the presence of insulin. And this is called leptin resistance, which really explains obesity. So when we know that, we know why bariatric surgery works, we know why these drugs we're going to talk to work, and we know why things in the diet and lifestyle that decrease insulin, like ketogenic dieting and intermittent fasting, they all work. And the reason is because they release that leptin signal. So that's my background. The second book came out last year. Paperback came out in January this year. It's got an added chapter on these drugs, Ozempic and Mounjaro, how to use them the smart way, which we can talk about in a little bit, Dr. Chichi, as well. So that's me. In the field of weight regulation, got intrigued by our lack of training. And, I think I've produced a book that really sort of outlines exactly what is happening with our population.
Perfect. Thank you so much, Dr. Jenkinson. I think that's really good. I think what I took out from part of this conversation is actually how to use this the smart way, because a lot of people go like, oh, I just want to get like Ozempic, I want to get a Mounjaro, and we're not thinking about how do we use it in a smart way. Obviously, we're losing the weight, but people are also reporting a lot of side effects, right? And I think what is really pertinent to this is that we all know that Mounjaro, Ozempic, and Wegovy have actually redefined weight loss and diabetic care. We can't take that away. And as a leading obesity surgeon, I just wanted you to share light about, I know you talked a bit about leptin, which is how it works, but do you think that, is it possible that this might actually influence fertility? We all know that obesity affects fertility, and you've said about how it works and what it blocks and how it gets your insulin working better. Do you think it can actually influence fertility in any way with the medications?
Yes, absolutely. So any type of weight loss will improve fertility. So we know that obesity in women can lead to polycystic ovary syndrome, and that then leads to infertility. We also know that there's a lot of emerging evidence that, obesity in men causes too much estrogen, which then sort of blocks the testosterone signal. You get low testosterone levels, you get poorer sperm function. So you can get infertility from the male side as well. And we know from evidence that any type of significant weight loss will, in women, unblock that piece polycystic ovary syndrome, and in men improve fertility and sperm function. So it's not particularly just these drugs, but these drugs are highly effective in resetting someone's weight. You get a 15-20% weight loss when you've been on them for a while. And I think they're a really good tool for people who are struggling with infertility. We know, if you're paying for infertility treatment privately, it's very, very expensive wherever you are in the world. And I think, these drugs are a really good adjunct. I would suggest, if you're eligible to go on the drugs, and 99% of people are, and you're struggling with weight and infertility, lose the weight first. It may be that you just need to lose the weight and then you become fertile and you don't need expensive infertility treatment.
Okay, I think that's a really good point about the fact that we all know that infertility is linked with obesity, and you've worked with like thousands of people struggling with obesity. And there's something you talked about how the drugs work, and I think sometimes people come up and say, "Listen, the Ozempic works better for me. Wegovy works better." From your experience, right? Do you think which of this medication delivers the most effective and sustainable weight loss? Is any one of them more superior to the other one, especially when it comes to things related to obesity?
Yeah, I mean, they're both good, but Mounjaro is the best. Mounjaro is, nicknamed the King Kong of weight loss drugs.
Yes, exactly.
The
Yeah.
combination of not just the GLP-1, which is this, hormone that's in Ozempic as well. This is, the way they work is the pharmaceutical companies have produced a copy or an analog of a natural hormone that comes from your intestine. And after you've eaten, when food starts to get into the intestine, sort of 30-40 minutes after eating, the intestine releases this GLP-1 hormone into the bloodstream, and that's then sensed by the hypothalamus, which is that part of the brain that that controls your appetite. And it's the signal for us to stop eating. Sort of half an hour after we've started eating, you get this profound signal that you don't really want to eat anymore. It sort of fits in with the old wives' tale of, if you want to lose weight, eat an apple 10 minutes before your meal, because then you won't eat as much. And it just sort of fits in with that. I mean, this old wives' tale is hundreds of years old, but it fits in with now what we know about GLP-1 drugs coming from the intestine. So they've produced a copy of it, and they've developed it to such an extent that now you just need one injection per week, and it will work pretty much for the whole week to block those receptors that GLP-1 affects in the hypothalamus to decrease your appetite. The second way the GLP-1 works is it improves insulin sensitivity, so it improves the efficiency of insulin, which means you need less insulin. And then going back to how our normal leptin weight control system is blocked by insulin. When you need less insulin, that leptin signal is released, and suddenly your brain can see, oh, whoa, we're carrying too much fat, and naturally you will go down. So these drugs work in both of those ways, as far as GLP-1 is concerned. So Ozempic is just GLP-1. Mounjaro is GLP-1 combined with another drug called GIP, which improves insulin sensitivity and function even better. So we see in the pharmaceutical studies that Ozempic causes around 12 to 15% weight loss in 6 to 9 months, whereas Mounjaro can cause about 20% weight loss. So it is superior, with, we think, probably less side effects. So Mounjaro is the one.
So Mounjaro is literally, I know a lot of people describe Mounjaro as the next generation drug, right? Like, and then you said that also people call it the King Kong of basically weight loss.
It's been named by the press, yes.
King Kong of weight loss. I like that because it has the additional effect. I was going to speak to you about something else. I think that weight loss is actually a game of numbers, right? That's how most people see it. But sometimes this medications are said to change metabolism, as you said already, insulin resistance and hormone regulation. Is there any other way they impact on fertility beyond just simple lowering of weight? I think people struggle with it sometimes because you hear these things about, oh, you're trying to have a baby, maybe you shouldn't be on Mounjaro. You're trying to do surgery, maybe you shouldn't really be on Mounjaro a few weeks to that time. I'm just wondering.
If you're using Mounjaro, Ozempic, these GLP-1 drugs, in order to eventually, become more fertile, you need to avoid, if possible, becoming pregnant, take precautions, whilst you're on the drug and whilst you're waiting for weight loss. We don't know, or the pharmaceutical companies don't know, whether there is any effect on the fetus if you're taking this drug and you get pregnant. So the pharmaceutical companies are very, very clear. You need to have a 2-month window from stopping the weight loss drug to attempting pregnancy again. It's quite clear, and we have to make that really clear to patients. The great thing about these drugs is, the weight doesn't rebound back up massively and suddenly, like if you were starving yourself on a diet and you came off the diet, your weight will go back on really fast. The appetite comes back over 2 or 3 months. It will come back, and you will put, the pharmaceutical companies, the data says you put 2/3 of the weight back on in the first year of coming off these drugs, and end up probably, heavier than you were beforehand. But, that weight doesn't pile on immediately. So you can plan, you can get down to your low weight loss plateau, then come off it for a couple of months, and then, plan for the pregnancy. But don't go on the drug and continue to try to get pregnant, because the pharmaceutical companies don't know the effect of the drug on a fetus.
On the fetus. Oh, I think that's really important, because I think that's what most people worry about. Is there going to be an effect on the pregnancy? What happens? And I think it's good to know that the take-home message is that, okay, you can use this to lose weight, but when you're planning to get pregnant, then stay away from the drug for some time, have the baby, and then plan. There's something you said that really hits me, which is the fact that the pharmaceutical companies are saying that you can gain this weight back. And I assume like what you do with your what you read in your book, you wrote in your book also about how we eat better to make this a lot better. I'm just going to ask a question, which is, I know you've helped countless number of people lose weight through both medication and surgery. And I think, and before we continue on the facts on fertility, what do you think is the most profound way for weight loss that impacts like directly on conception and fertility, that is easiest? Just thinking about drugs, surgery, and everything together before I go back on like the drugs that we're talking about, because I think that's really important for people to also think about that sometimes when they're thinking about conception and weight loss to help.
You say, what's the best
Way to actually lose weight and sustain it?
well, whatever you have, whether you have the surgery, which is the most effective, you're going to lose 30-40% of your weight, or GLP-1 drugs, which are pretty effective and pretty low risk, 15-20% of your weight, but you've got to keep on the drug. Otherwise, you put the weight back on, unless you use it the smart way, which we'll talk about in a bit. Or change of lifestyles. If you've got, dietary and activity lifestyle changes. So if you've got terrible eating habits, if you're eating, takeaways and fast food and sweets and snacking all the time, and you actually change that round, you will lose a substantial amount of weight without counting a single calorie. So all of these things have got to be long-term lifestyle changes in order to, get that nailed on change of your weight set point, where your body wants your weight to be. As far as, the most effective, it depends on your weight. I mean, if you're 150 kilograms, then, even if you had the weight loss drug, it probably wouldn't be enough, To get down to 80 or 90 kilograms, you'd need a gastric bypass or a sleeve. Whereas if you're 100 kilograms, you can get down to 80 kilograms with Mounjaro. So if you're 90 kilograms and you've got bad eating habits, you can get down to 80, 75 kilograms by tightening up their eating habits. So it depends what level of obesity you have and your eating behavior, as a baseline beforehand.
Okay, thank you so much. So what you talked about is the fact that the amount of weight you lose is also dependent on obviously the lifestyle changing. So as you take Mounjaro, Wegovy, or Ozempic, it's good to think about looking at your food. And obviously you've talked about how do we eat too much, why are we eating the wrong meals? And then also what else are we considering? Obviously, if the weight is like so bad, like it's really high, then maybe we should be thinking about all the things that we should be doing, isn't it? All obviously to be able to like not be part of this 1 billion people globally that are affected by obesity. And then more importantly is to get your fertility to be a lot better, because your hormones are working better and things are actually a lot easier. Like your metabolic health is a lot more improved. Is that correct?
Yeah, so if we talk about using the drug the smart way, so
Okay.
so in my first book, I outlined the eating behavior and the change of habits and diet that you need to do in order to, reset that weight set point to a healthier level with diet and activity, diet and lifestyle. Okay. which is lowish carb, not keto, but lowish carb. Uh, Not eating processed foods, trying to give up sugar if you can. Obviously, don't give anything up. If there's a birthday party, have some cake, whatever. But as a your normal routine, not have sugar, not snack. Sleep well. Try and de-stress if you can, and do a bit of exercise that you enjoy. Now, all of these things are going to reset your weight, but people reported back that it's difficult to give up sugar because it's a drug that makes us feel good, and some people rely on that. Um, so those lifestyle changes that we want people to make can be really, really difficult because we've got these ingrained almost addictions and habits and things like this. Really, really, really difficult to change. But when you're on the drug, Mounjaro or Ozempic, you really don't feel like eating rubbish. You don't feel like, if you drink too much wine, you don't feel like drinking wine. A lot of people report this. So it can really break those habits. So if you're on this drug for instance, a year, and you have a year of not mindlessly snacking in front of Netflix in the evening, or snacking in the daytime or whatever, that's going to slowly erode those habits in your brain. The habits are never going to go away totally, but you can replace them with better habits. And then if you wean yourself then off the drug, and you're taught what foods are really good for you and what foods are terrible for you, almost like change your identity so you really, really understand food. And it's not you're not using willpower. It's just that you understand the food environment so well that you don't want to eat that bad food. You don't want to eat the burger. You don't want to have the sweets because you know what it does to your body, like how metabolically poisonous it is to you. If you can use the drugs that correct way and educate yourself at the same time, you can wean yourself off the drug and not, re-put the weight back on. Because the alternative is you're actually then dependent on a drug that in the UK costs around about £200 a month. In the US, if you're paying for it, it's $1,000 a month if you're not insured. So these are very, very expensive drugs to be on, lifelong. We don't know the long-term effects of them. They've been around for a while because they were used for diabetes before. Been around for at least 10 years. But yeah, there's a question mark about what happens if someone's on these drugs for 10, 20 years.
Yeah. So really what we're saying is that the drugs can help you restart your weight loss and obviously invariably help fertility, but we need to look at the holistic way of literally thinking about what we're eating. Are we putting in some exercise, and we need to make a lifestyle change. So I think people have described the drug as almost where they don't have that food hunger, right? And they basically are on a food holiday. So I guess what it is, I know I was reading something recent and a person says, listen, all of a sudden I woke up and I'm on this magic drug and I actually don't feel like I need to eat, if that makes sense. I'm not having that craving, like you said, even with red wine, even with things that people like sweets and stuff. So what we can use this to do also is obviously use it to kickstart what we're doing, do a bit of maintenance, and then obviously literally change our whole lifestyle. That's what we're saying in a nutshell about how this works. And I think one thing I really want to talk about before we take questions from the audience, please, if you have any questions, just put it in the chat box and I'm going to get Dr. Jenkinson to answer your questions. A lot of women are struggling with PCOS and invariably infertility, and some of them will turn to those drugs for help, right? Can this GLP-1 medications actually restore ovulation in PCOS patients? And if they did, I don't know what your experience is with that, with PCOS and people going to GLP-1 agonists to help them.
Yeah, I mean, the answer is yes. So basically, PCOS or infertility, if someone is, severely overweight, or if someone's anorexic and doesn't have, enough weight, if they're a bit unwell, whatever, that's like a evolutionary design. We don't, the body, the human body doesn't want to become pregnant when they're either carrying far too much weight or not enough, because the baby's going to have difficulty surviving, the parent is going to have difficulty looking after the child. So the human body is hardwired to only want to be fertile when they're relatively normal weight. So when you're overweight, that reaction is that the ovaries start misfiring and you're not ovulating properly. So when you do lose weight through surgery, these new GLP-1 drugs, or changing your lifestyle and diet, you will regain that fertility. Your ovulation will come back to normal and you'll regain it. I have a lot of patients actually that, you know, they go through, particularly the patients who have gastric bypass, and they're really big beforehand. They lose a lot of weight at first, and they then become amenorrheic. So they don't have periods for 3-4 months. And they say, doctor, what's happening? And they say, look, this is just the human body's way of saying, we do not want babies at the moment. You're not eating enough. You're losing too much weight. It perceives that there's like a famine situation going on. There's no food available. It doesn't want a pregnancy. So, but then when they start to plateau, when the weight starts to plateau at a healthy level, then the ovaries start firing again and start, you know, working properly. And that's when fertility, you know, properly comes back to relative normality.
Okay, thank you so much. Thank you so much. I think I'm going to go to the questions from the audience because we almost have first. And I know I have more questions for you, Dr. Jenkinson, but I was just going to take some of their questions and then we're going to go back to the conversation again. So the first question I have is someone says, I'm currently on Mounjaro 5 milligram and I have lost 12.5 kilograms so far in 12 weeks. Now my friend is also on the same medication, but she hasn't lost any weight or had suppression so far. Why is that? Can you shed light on why this happens, please?
The question of her, what dose is she on?
She's on 5 milligram and she's lost 12.5 kilos in 12 weeks, in 3 months, right? Her friend is on the same medication but hasn't lost any weight or had any suppression at all from her appetite.
This is a very good question, because it sort of explains how the drug works and the frustrations at low doses sometimes, and the reason that you shouldn't go straight onto a high dose and then go onto the internet and say it's a terrible drug, which is what a lot of people do. So the drug works differently for different individuals. For Mounjaro, there is a range of the doses from 2.5 milligrams once per week all the way up to 15 milligrams. And it goes in 2.5 increments. So you go 2.5, 5, 7.5, 10, 12.5, 15. Most people don't need to get to 15. Most people in my experience will probably settle on around about 10 milligrams. You know you're at the right dose when you literally don't have much appetite, but you will eat a small meal once or twice a day. You're losing weight, but food is not an issue. Okay, that's when you're at the right dose. And for different individuals, it could be 5 milligrams for someone, it could be 12.5 for others. You know, most people it's around about 10. Okay, that's the right dose. Appetite off, but no unpleasant side effects. If the dose is too high for you, you're going to get this feeling of quite unpleasant nausea, you know, for several days after taking the drug, almost like a motion sickness, a seasickness, a really unpleasant feeling that you can't really concentrate. So clearly you're not going to eat anything then, but it's not very pleasant. That means the dose is too high, you need to come down. If the dose is too low, you still have an appetite. So for instance, if your ideal dose is 10 and we start you on 2.5, then you're not going to feel much at 2.5 or 5. You might start to feel a little bit at 7.5. But we can't start people straight on high doses. You know, the companies are the pharmaceutical companies are very clear that we need to start on lowish dose and then build up every month. So you start on 2.5 or 5, and then you build up slowly. So it usually takes 2 or 3 or 4 months before you're on your own optimal dose. These drugs are pretty safe. The contraindications are very rare. If you've got a family history of a particular type of thyroid cancer affecting any members of the family, then you shouldn't take it. And if you previously had a condition called pancreatitis, you shouldn't take it. If you're a little bit old and your kidneys are partially failing, again, you shouldn't take it because you sort of don't really drink much water if you're on the right dose sometimes. So that can affect the kidneys. But otherwise, as I say, 98% of people probably are fit enough to take this drug. The drug confers a risk of pancreatitis, which you'll have heard in the press as well. It's a 10 times risk of pancreatitis. But, you know, when you quantify actually what that risk is, it sounds like, oh, whoa, 10 times risk of pancreatitis. Actually, the risk of pancreatitis is 1 in 5,000 a year for us. You know, so it goes down to 1 in 500 per year. So it's still extremely low risk. And most pancreatitis is self-limiting. It's 80, 90% is you feel quite unwell for about a week, but it goes away. So the answer to that question, Chi-Chi, is it's understandable. And I think, the friend that's not feeling anything probably is going to need a higher dose, and she will feel something once you get to that dose.
Perfect. Thank you so much. And so I guess the question is they just need to be on a higher dose, but as you said, it has to be given safely. I think that's what I'm stressing about, people being monitored by a proper doctor, making sure they're monitoring what's going on. I think the next question is I've heard that these drugs affect bone density and one starts to get saggy eyes due to the muscles getting weak. Does it happen with all the drugs and to all patients? Is there a way to prevent this?
I think any weight loss, you need to be careful, to maintain muscle mass. So we would advise people to take in around about 60 grams of protein a day if they're on this drug. So they're not going to be feeling very hungry. They might be that they just need to take a protein shake, a protein yogurt, just to build up that protein so they don't lose too much muscle mass. We want a little bit of low grade, muscle activity, maybe in the gym or at home with some mild weights. And probably, if you're female and middle-aged, you probably got to be a little bit concerned about bone mineralization. We don't want osteoporosis. So yeah, probably it would be sensible to take a calcium supplement at the same time. As far as sort of the saggy eye thing, I think that may be a bit of an Instagram or Google rabbit hole someone's gone down, and I haven't heard that. But certainly if you lose a lot of weight, you're gonna, particularly, well, it could be men or women, but usually women are worried about the way their face looks. You're going to lose a lot of your natural fat fillers, which make you look, relatively healthy. A lot of people pay a lot of money for fillers. So you're going to lose that if you're on, too much of the drug, too high a dose for too long. A lot of people who have eating disorders, so they're like semi-anorexic, love the drug. They're getting it, illegally, without supervision. They're putting themselves on mega high doses, not minding about a little bit of nausea, and literally not eating for 2 or 3 weeks on end. And, clearly they then become skeletal and they'll take photos of themselves, put it on Instagram, it becomes really famous. But that's not how the drug should be used.
Thank you so much. So a few people have complained about delayed period while on Mounjaro. These are people that have regular periods prior to coming on the medication. Why is this?
Sorry, so repeat the question again, Chichi.
A few people have complained about delayed periods
Mm-hmm.
while on Mounjaro. These are people who have had regular periods prior to coming on the medication. Why is this?
So this is going back to what I previously commented on. So the human body does not want to become pregnant when there is a perceived threat in the environment, i.e. you're losing weight because you're not eating. It switches off fertility. Fertility is one of the first things to go. It does not want that human body to be carrying a baby and all of the extra energy that's going to take if you're losing weight. So infertility or amenorrhea or dropping or delaying periods is a normal consequence of active weight loss. Now, once your weight plateaus at a healthier level, those periods will come back. So it is normal to affect, your menstrual cycle.
Okay, thank you so much. So the next question says, I take Mounjaro. Can I take Mounjaro with acid reflux? I'm on a famotidine 20 milligrams daily.
So this is a really good question as well. So, one of the side effects that we see is, apart from, severe nausea if the dose is too high, is that, GLP-1, the hormone, delays gastric emptying, so it stops the stomach emptying, which makes you feel fuller for longer, and has that effect of decreasing your urge to eat. But also, if that delay of the stomach emptying is significant, the stomach's going to fill up with acid, as it normally does. It produces 2 to 3 liters of acid per day. Even without you drinking anything, it's going to produce a lot of acid, which goes around the system, gets reabsorbed. If the stomach's not emptying, that acid is going to be sitting in the stomach. If you're prone to reflux, you're going to get worsening of reflux. You're going to get heartburn, etc. There are good drugs you can take to, totally switch off that acid pump in your stomach. But again, you need to titrate those drugs up. If you're just on a low dose, it's not going to be enough. So things like omeprazole, lansoprazole, pantoprazole, these drugs ending in azole are all profound acid suppression drugs, but you need to be on the right dose again. It might be that you need to be on it twice a day. So that would be my so having reflux is not a contraindication to taking these drugs, but the reflux might get worse, and you may need to up your dose of whatever acid suppression drugs you take.
Okay, thank you so much. I think I'm going to take another question says, what are the common side effects of the drugs? I think because we're talking about side effects, I'm going to do that and I'm going to come back to more questions. What are the common side effects of the drugs? Like, because I think a lot of people have different complaints, and I think social media doesn't help it, isn't it? You have one people talking about, oh my God, is this magic drug? And the other people are talking about all these things that go wrong. Oh, my tummy is not working well now, 2 years later, and things. I think it's good to cast an eye on it, like scientifically, because when
Yeah,
it
so the common side effects, I mean, for the first dose, even at the low dose that we start people on, 1 in 20 people are going to feel terrible. They're going to feel like they've got gastroenteritis. So they get diarrhea and vomiting and just feel awful for 24, 48 hours after taking the first low dose. I encourage those people to take the second dose the week later because invariably it's okay. You know, the body's just had an initial reaction to the first dose. Second dose, actually, they say it's okay now. So that's the first side effect. 1 in 20 people, really bad reaction to the first dose. The second side effects we've sort of talked about a little bit. If the dose is too high, you feel really unpleasantly nauseous, motion sickness type nausea. Some people who've got reflux may get worsening reflux. And the other thing, you know, related to that lack of gastric emptying is sometimes then the stomach can build up, you know, bad gases, and people report this sort of sulfur gas. So the whole of the intestine is not working properly, and you're burping, you know, pretty bad smelling burps, you know, almost like flatulence, but like, so it's really quite unpleasant, which means that people have to stop the drug. It's quite unusual. It tends to occur if people have been on the drug for a long time, like a year. But yeah, it's unpleasant and people have to then stop the drug. It then takes a little while for the stomach to reboot and get back to normal again. It does get back to normal, but it sometimes takes a little while. But they're the common effects, nothing majorly serious. And obviously we mentioned the risk of pancreatitis. You'll see, you know, because millions of people are on this drug, and all of those millions of people have got a 10 times risk of pancreatitis, you will see in the media, for instance, there was a report that 80 people in the UK have died from this drug. That will be from pancreatitis. When you look at the bigger scheme of risk benefit, actually, you know, there's a lot of people who have lived already a lot longer who haven't died from heart attacks because, you know, their weight loss has taken the strain off the heart, etc., etc., etc. So the risk is still very, very low, and the benefit is still pretty high, you know, for lots of different reasons.
Thank you so much. I think like the truth is that obviously obesity affects your heart and different things. And as you said, if that reduces your risk, then pancreatitis, like the rate is really low. It makes more sense that more people are leaving because they're losing the weight that they need to lose and they're living healthier lives more than anything else. And obviously, if you're well monitored and you've got a doctor regulating what you're taking with the medications, then your side effects are actually better controlled and you're able to like navigate the whole experience better and obviously get your lifestyle together. I think one thing I was going to ask is that people can be on this medication, but I think it'll be nice for you to share your approach to lifestyle changes, right? Because as we said, the medication is fantastic for the, I don't know, the first year, second year, but we need to do a lifestyle change. And I think having that approach, which is something I really gained when I read the first book and was like, it's just fantastic about what you should be eating, what you like, you know, like how you regulate stuff. And I know we've had this conversation a couple of times back and forth. And I think it's good for people to live knowing, yes, it's safe to take the medications, but your lifestyle has to change for it to be sustainable or you're back to square one.
Yeah, this is how to use the drug the smart way. I mean, my new company, mymetabology.com, is providing like a weight loss program, a lifestyle program to go alongside delivery of GLP-1. We hope that will eventually become international. Maybe you can get involved with that as well, Chi.
Yes, definitely. Definitely.
Yeah, because I think it's something people want to use the drug, but they want to use it the smart way. They want to be able to come off the drug as a different person.
Mm.
the interesting thing is when we talk about what we do, bad habits and things like this, habits control literally 40% of our behavior is subconscious. It's just we see something, we do it. You can imagine getting up in the morning, getting washed, having breakfast, going to work. It's all semi-subconscious. We're on autopilot. We're so used to it. We don't have to think about anything. But this controls most of our life, including our bad habits, including picking up, snacks, unhealthy snacks, whatever. It just is wired into us. If you use this drug, you're not going to get the urges to, do some of the bad things that you were doing before. It can profoundly change those habits. And habits are a little bit like, as I said before, they don't go away. If you imagine, it's basically brain, channels in your brain that are used very, 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 very commonly. And it's just the lazy and the easy way for the brain to work. Imagine a habit as if you're in a forest and you imagine those little tracks when people are walking from one part to the other, the more people walk along them, the more ingrained the track. Eventually, if it's a really popular route, someone's going to build a path or even a road on it or even a highway. These are habits. If you do them all the time, it becomes like a real ingrained road in your brain. However, if you don't use that habit or do that habit for a period of time, like a year, that path is not going to go away, but it's going to get overgrown. And then hopefully in that year, you're going to be promoting and doing new, healthier habits. So you're going to produce different pathways, healthier pathways in your brain. And when you come off the drug, hopefully those pathways are going to be the dominant ones and you're going to carry on. And if you rely or at the same time that you're on the drug, really, really, really educate yourself about your food environment, how toxic some foods are and why they're toxic, you automatically just go off those foods. You don't want them. You're not relying on willpower anymore. Because if you don't understand food and you don't understand, that sort of willpower and the way your brain works, when you come off the drug, you will become hungry again and you will probably fall into bad habits unless you've literally changed your identity during that time that you're on the drug.
Thank you so much. I like that fact that you said you have to change your lifestyle. You have to change your identity. You need to learn about food. And again, that's what I talk about. Like, I think that's why today is important about you speaking to us because you understand food. Like, you speak food, if that makes sense. Like, and I've had that conversation with you so many times. And I think it's just amazing knowing that, yes, these drugs are great for you. They're going to get the weight loss off. They help fertility improve because you're losing more weight and your hormones are working better. But you need to actually change that lifestyle to be able to sustain it. I love that.
Yeah.
Thank you so much for that message. I'm
Yeah.
going to take another message, another question, which is I work in respiratory medicine and I'm interested in the effects of these weight loss medications on obstructive sleep apnea. Is there any clinical trials? And do these medications cause loss of okay, I think you talked about lean muscle mass, but he's asking, do they cause loss of lean muscle mass in the diaphragmatic dysfunction in the diaphragm itself with breathing?
So the question is, does
Are there effects on
drugs
obstructive
improve
apnea?
sleep apnea and what's the effect on muscle mass?
On muscle mass with diaphragmatic dysfunction, and also whether there are clinical trials on it with obstructive sleep apnea.
Um, I'm not sure about any clinical trials, but when people lose weight, sleep apnea improves. We know with gastric bypass or sleep hysterectomy surgery, 90% of people who have sleep apnea, they'll go into remission. They won't need the CPAP machine. They'll stop snoring. They'll sleep a lot better. So you don't need a study uh, to confirm that weight loss improves sleep apnea. It will do. So if you take these drugs, if you've got sleep apnea, if you lose weight because of the drug, the sleep apnea will significantly improve and may go away completely. What was the second question about? Something
It
about
says
diaphragm?
that does because of the loss of lean muscle mass with the weight loss, does it affect diaphragmatic dysfunction? The diaphragm.
Okay, so lean muscle mass is skeletal muscle. This is like muscle that we use consciously when we're doing things,
Mhm.
wake or whatever. Uh, as I said, previously, any weight loss is going to affect muscle mass, which is why you need to take 60 grams of protein a day whilst you're losing weight, just to try and avoid that, and do a little bit of toning exercises just to keep that muscle mass up. The diaphragm is not a skeletal muscle, so it's not going to affect the diaphragm.
Okay, thank you so much. The next question says, thanks for your response. Mention something regarding know your right side when you are on suppression. So is it that advisable to repeat a particular dose? Because I have heard many people say you don't have to repeat doses, instead move up every month.
No, you don't have to repeat doses at all. And, you can use it the smart way. You can use microdosing. A lot of people, they want to use a little bit of willpower, but not feel, overwhelmed with hunger. So, I mean, these people may just want to be on a low dose. They may still want to enjoy food, but, not have that overwhelming urge to eat rubbish all the time, which is what, hunger does. It wants you to have the really bad calories. If you can take a little bit of that away with a low dose, you're much better managed to be able to then just eat healthily. So a lot of people do want to be on just a little dose, not so much that they're, not wanting to go out and enjoy food with family and friends, that sort of thing. Other people want to be on the highest dose and lose as much weight as possible. So it can be used, in a tailored way. The other thing people do is they want to maybe have a little holiday from it for 2-3 months and see if they can maintain the weight loss. So that's reasonable. I think when those people restart the drug, you don't want to restart at a high dose suddenly. You've got to restart at a lower dose again.
Thank you so much. Is Mounjaro advisable for patients who have had a gastric bypass 2 years ago and have not gotten to the expected weight loss?
Yeah, very good question. The answer is yes. So we don't know, or we're just finding out why some people don't do so well after gastric bypass, but particularly the sleeve. 15%, almost 20% of people after the sleeve are going to have suboptimal weight loss or weight regain. And we don't know why that is, why there is a biological difference in response to various different people with the same operation. And it tends not to be what they're doing, and these people do really, really well when they've, had the suboptimal response from bariatric surgery. Then they go on the drug, they start to lose weight. So I've got a number of patients who, they wanted to lose a little bit more. They were starting to struggle, starting to weight regain. And it's a really good adjunct to bariatric surgery.
Thank you so much. The next question says, please, what are the alternatives to sugar? What do you think about sweeteners?
I don't have a big opinion. We know that sugar is, obviously it's going to increase insulin levels, and the more sugar you have, the higher the insulin level, and the more that's going to block that leptin signal, your normal weight regulating system, and it's going to disrupt everything. And, you're going to struggle with weight control because of sugar and insulin. So sugar replacement in that respect is good. Anything other than sugar is good. I had heard reports that, for instance, if you have Diet Coke, the brain thinks you're taking in sugar because it tastes like sugar, and then you get hungry because it releases insulin. I haven't really looked deeply into that, and I'm not sure whether that is true, if you're going to be more likely to snack after a Diet Coke or not. I don't think so. So I'm not a big advocate of any type of artificial food or flavoring or whatever, but I don't think it's obviously harmful.
Okay, thank you so much. And the next question says, which would you recommend to someone who is highly overweight, gastric sleeve or Mounjaro?
If they're highly overweight, then gastric sleeve. If they're slightly overweight, then Mounjaro.
Okay, thank you so much.
If they're highly overweight, they're going to, spend a load of money on Mounjaro and not lose enough, and then end up having a sleeve anyway. So you may as well just have the sleeve or the bypass operation, with good advice around that, so that you don't need anything more. So you can use the operations, profound, life-changing procedure. People are just so much more confident. They've reset their weight to a healthier level. They feel like their young selves. They feel fit. They don't really have the urge to eat bad food. So the surgery is pretty good as well. Very good.
Thank you so much. So the next question says, there are a lot of nutritional deficiencies that accompany rapid weight loss. Are there concerns that this medication can deplete things like your folic acid, your zinc, and vitamin D? Should we be taking these supplements while we're on the medications?
Yeah, as mentioned before, I think any calorie restriction, uh, you're at risk of developing a vitamin or mineral deficiency. If you're on these drugs for a long time, you lost a lot of weight, then I probably would advise taking supplements. Certainly, it's not going to do any harm. And it may be worthwhile just checking on a blood test those vitamin and mineral levels if you're concerned.
Okay, thank you so much. And then I was going to this question says, what if you get pregnant while you're Mounjaro? Are there immediate health risks to yourself and the baby? What do you do in that situation?
First thing is to come off the Mounjaro. You don't want to be taking it whilst you're pregnant. We sort of, talked before about the uncertainty regarding pregnancy and the effect of these drugs on the fetus. Pharmaceutical companies are a little bit worried about it. However, I mean, the drugs have been around for 10 years as diabetic treatments, and we would probably have an idea of problems with pregnancy and these drugs if it was an association. But they say be cautious. So my advice would be, if it does happen that you're taking the drug and you fall pregnant, then just stop taking the drug. And then just go to your normal antenatal clinic. Tell the nurse that you've been taking it. Any active weight loss during a pregnancy will increase the chance of a miscarriage. So, for instance, when we do the surgery on ladies who are childbearing age, we say you've got to be cautious and try and avoid getting pregnant for that year that you're losing weight. Otherwise, an increased chance of miscarriage.
Thanks a lot. And then the next question says, is there any studies linking GLP-1 receptor agonists to changes in sperm quality and motility? Should men who are trying to conceive be aware of this?
Again, I'm not directly aware. There probably are studies either already out or imminently out that will show an improvement in sperm quality and testosterone levels. We know any weight loss will improve both of those criteria. So I'm sure weight loss secondary to these drugs will do that as well and improve fertility from a male point of view.
Okay. Okay, thank you. Let me see. Okay, if you're just joining us, please, if you have any questions, I'm going to take two more questions because we're always towards the end. And I'm going to do the next question, which is, for couples struggling with infertility, should weight loss medication be considered as a part of a standard fertility strategy? Or is there too many unknowns, like for the couple themselves? Should they both be trying to lose weight, even if they're overweight? I think that's the question.
If you're infertile and you're obese, so body mass index over 30, as I sort of said earlier on in the interview, in the question and answer, I think it's much more sensible to try and lose weight, before you seek fertility treatment. So if you can get your body mass index down towards a normal level, it might be that your fertility just comes back. And therefore, I would suggest that, if your fertility could be due to obesity, that, tackle the obesity first with these drugs, and then see if your fertility comes back. That would be the sensible way. These drugs are, okay, they're expensive, but they're not as expensive as fertility treatment.
I think someone else has written, thank you. Someone else has written, since I've been on Mounjaro, I have been vomiting nonstop, right? What should I do to avoid this? Am I eating wrongly, or am I eating too much? Or is there something I'm doing wrong?
I think the dose is too high, far too high. So you just need to reduce the dose, seek, professional medical opinion. But it sounds like anyone who's vomiting means, the dose is too high.
Okay, thank you so much. And I think like I'm gonna stop here because I know you've just finished operating, like you're tired. Honestly, this is like thank you so much for like talking to us about people are writing things, so really useful webinar. Thank you so much for like joining us because I know you're at work, right? And I was going to say something that you talked about that I think I want people to go away with, and that is like using the medication in the most safest way and being monitored while you use it. I think some people are just joining, but we're round enough. And actually using it and let it be monitored by a health professional that knows what they're doing. And I think that's really important about our take-home message. The medication works, but it needs to be used wisely. And obviously, I think the take-home with people who have asked questions on fertility is that we need to take this medication when we're just to lose the weight and then try to get pregnant. That's the take-home message. I was just wondering, is there a final word about that you were going to leave us with, Dr. Jenkinson, before I read all the other comments?
Just that the drug is, it is, my patients really like it. I think anyone who's tried it, it is a groundbreaking new drug. It's not a total panacea. You've got to use it preferably the smart way, and you've got to use it under medical supervision. But yeah, they're new important development in weight loss management.
Thank you so much. So thanks everyone. So thanks everyone who is joining wherever you're joining from. So I'm going to say good evening from London and Nigeria. And then if you're in America, that's good afternoon. Thank you so much, Dr. Jenkinson, and see you later. Thanks everyone for joining.
Thanks.